because I have the, I also try to test on the, learning. Okay, so we all know people that have experienced traumatic events, right? And those that have been, okay, if you just came in, make sure I check your name. Kia. And so, of course, these stressors are more than what we just have in normal daily life. And examples, of course, are gonna be like the war, terrorist attack, natural disasters, those kinds of things. You know, I'm sure people in, both of those recent plane crashes, you know, or the ones, the people that saw it or had family members, you know, that were involved. And then, of course, you know, all the things that have happened, the 9/11, which is a little further back. And, the California fires, you know, a lot of people have lost their houses. My future daughter-in-law has, some family members that have had to evacuate, and, a childhood friend that lost her childhood home. So, they live in Irvine. So, but my daughter, future daughter. So characteristics of stress and trauma. All persons can experience anxiety, insomnia, difficulty coping. But most of us work through it, right? Somebody dies, we may have grief in the beginning, or we fail a course and we're pretty devastated, but then we get ourselves together and we retake the course and we become nurses. And but some individuals have problems coping. They just can't seem to get back to where they need to be. And those are ones that we have, they can develop disorders like adjustment disorders, acute stress disorder, PTSD, and dissociative disorder. And we'll make sure you put your name if you do. So we'll talk about these. Post-traumatic stress disorder. Y'all know what that is, right?
Mm-hmm.
How many of you have known somebody with PTSD?
Shoot, I got it.
You know, childhood trauma, ACEs, acute event, and so the, of course, the event posed actual or threatened death or serious injury. It can be intense fear, helplessness, or terror. So a lot of, you know, and counseling helps with PTSD. I know my niece's husband had PTSD after one of the wars, and he's okay now. He went back, got his mask, but it took him a while. For a few years there, you know, he didn't talk to people too much, and we thought something was kind of wrong with him, and then we found out what had happened, and he did get the counseling he needed and went back to school and is doing very well now. But everybody doesn't. Everybody doesn't get the help they need. So some people, and y'all see TV shows all the time with people with PTSD, and they have dreams and they wake up screaming and that kind of stuff. Well, all that's real. And they may have trouble concentrating, where they have intrusive, recurrent thoughts, and they have avoidance behavior where they just try to stay away from people. They want to do as few social events as possible. And then they may have negative cognition, negative thoughts. And so they're kind of like constantly on guard. They're like hyper vigilant, you know, where they're always, they hear noise, they're looking around because of what they've been through. And this little box in your book is part of the chart. And but this is, you can see your ebook for the full chart, but I'm not, you don't have to know this for your test, other than generally. In the past month, how much were you bothered by? And so this would be like a questionnaire they would give them. And do you have the repeated dreams and sudden acting or feeling if it's happening all over again? Do they relive it? You know, maybe in their mind they do. And strong physical reactions, like if their heart starts to pound and they have trouble breathing, they have like a panic attack with it. They may have, you know, maybe the memories, in avoiding external reminders. So such as people, places, conversations, that kind of thing. Maybe somebody shows up that is involved with this. Trouble remembering some of the important parts. They may all of a sudden start to piece it together. I know you've seen police shows where people, you know, were involved in killing somebody accidentally or whatever, and all of a sudden it comes back to what happened. If you just came in, make sure you mark your name on here. And then have strong negative feelings of victimhood, such as fear, or anger, guilt, or shame. And then some of the related disorders, adjustment disorder, reaction to stressful event that causes a problem. And that is maybe about a month after the event happened, they start to have some problems, but a lot of times it won't last more than about 6 months. They'll kind of get themselves together. But if acute stress disorder occurs 3 days to 4 weeks after the trauma and can be a precursor to the PTSD. And then there's the reactive adjustment disorder and the disinhibited social engagement disorder. And those usually occur before the age of 4. It might be a child that's sexually abused or experienced some type of child abuse, another type of child abuse. So for it to be PTSD, there has to be a causative trauma. And it's got to be associated with the event exposure rather than personal characteristics. And then part of what makes it worse is lack of social support, peri-trauma disassociation, previous psychiatric history, personality factors can increase the risk. So if somebody has a tendency for problems with mental illness and that runs in their family or something, they may have a harder time with PTSD than somebody that's got really good coping skills, and you know, if they get some counseling and good support systems, then they'd be okay. And then for the adolescent, they're more likely to have PTSD than children or adults. And those of us that were on the, excuse me, the child and adolescent unit this last week, we saw a lot on Saturday. We saw a lot of kids with, that had PTSD that were, some of them were acting it out, and some of them were just not coping at all. And there is an increased incidence related to the following: age, gender, type of trauma, and repeated trauma. So adolescents have an increased risk for suicide. You know, the increase with suicide has been unbelievable. When I was house supervisor at Lavana's, any given week we had a couple of kids that we had to have sitters because they had attempted suicide. Girls tend to take Tylenol and that kind of thing, whereas boys tend to use guns, which is more permanent. But either one, Tylenol can wipe out their liver and they can end up in ICU and dead. They may turn to substance abuse, and you have to look at their social support. If they have poor social support from family members or foster parents or whoever, whatever home they're in, they're not gonna do as well. And that's what we see a lot of at Lakeside, that families have just gotten tired of them and they don't want them back sometimes. They've caused so much disruption in the home. And then academic problems, those will be manifested. And that can also be from depression. You know, they just don't have the energy to do their academic work. And then they may have poor physical health because they're depressed and they're not eating well. They may quit exercising. And then some cultural considerations. It is universal. There's lower levels of resilience and poor long-term outcomes in countries where there's not a lot of support systems. And then a stronger sense of self and cultural identity. There's less frequently diagnosed with PTSD. So that basically just has to do if they have good, strong support systems from their families and friends. And some of the options, they can do counseling and therapy, they'll do both, most of the time. They'll do individual therapy, they'll do group therapy, especially while they're inpatient. And then if they do intensive outpatient, they may still have some group therapy, but they always have to have some individual therapy with a therapist. Now, sometimes the therapist is not a psychiatrist. Sometimes it's a social worker. A lot of social workers are also therapists. And then there's also degrees just in therapy. So you'll see all of that. And then if they think medications will work after they do, all their liver and kidney function tests and enzymes, they'll start them on medications at the lowest possible dose. And then the cognitive behavioral therapy and the specialized therapy that we talked about on the last test, exposure therapy, relaxation techniques, adaptive disclosures, and all these are in your book, cognitive processing therapy, and community-based care. And then they'll do everything they can to promote mental health by giving, hopefully they will have community places where they can it's harder for kids that live in rural areas if they don't, if they have to drive back to Memphis, they may not have, families may not have transportation, and so they have to try to find something in their city or town. And so that's always an issue with kids that don't have transportation or good support systems, is the follow-up care. And that's a big issue. With your dissociative disorder, it's like a subconscious defense mechanism used to prevent recognition. So your body just, kind of doesn't think about it. Becomes easier with repeated use. Essential feature, disruption, and usually integrated functions of consciousness, memory, identity, and environment. So they can, onset can be sudden or gradual. And with this, you'll see this with PTSD, you have problems with relationships, they have problems doing their daily living and just coping in general. And there's different types of it. One of them is the amnesia, where they just don't remember the event. And then the identity disorder is where they actually develop multiple personality disorders. And y'all probably seen TV movies and different things about multiple personality disorders, but it's real. Don't see it a lot, but sometimes on West Unit we see it. And I know when I had students at Mental Health at Methodist North, it seems like there were one or two people that had the multiple personality disorders. And then there's people that just kind of depersonalize with it. So these are the more detail on it. You're disassociative, they can't remember the important event. And it includes experience where the client suddenly moves to a new geographic location with no memory of past events, and often assumes a new identity. You've seen people like in a wreck or something, and they don't remember where they are, and then this is dissociative identity disorder, and this is where they actually do have two or more distinct identities, and it depends on which one. When you're talking to him, takes control of it, make sure he's done here. And this is accompanied by the inability to recall important personal information. And help yourself to cupcakes if y'all just came in. I like your hat. Thank you. Depersonalization, utilization, this is where they've got a persistent or recurrent feeling of being detached from his or her mental processes. They have a sensation of being in a dreamlike state in which the environment seems foggy or unreal, where they can't believe this really happened to them, and they just kind of, don't think about it. The client is not psychotic nor really out of touch with reality. They just feel kind of detached from it. And dissociative, the sudden unexpected flight from home with an inability to recall events from one's past. And that was not in your textbook, but I just wanted to put it in here. Okay. The treatment, again, individual therapy, they need, real good one-on-one therapy. Sometimes they'll do trauma therapy, and trauma therapy can involve the EMDR, DR, and it's where they do the tapping, and there's some other forms of it. Group therapy, and then focus is to reassociate their thoughts. And, of course, they'll do medications for anxiety or depression or both. And then, they want to, the goal, of course, is always gonna be for them to have the best life possible, and including being able to function and take care of their family and take care of themselves, and to reduce symptoms. When somebody's admitted to inpatient psychiatric unit, sometimes maybe they aren't taking showers at home, and they're just real disabled and stuff, but, then that's part of seeing if they improve, if they start to, get up and take care of themselves. And anytime somebody's depressed, you can tell that's one of the things. Or if they start, giving stuff away that was valuable to them, it could be a sign they're getting ready to be suicidal. So some of the nursing interventions, of course, is to create a safe, calm environment, and to teach stress management and coping mechanisms. And then discuss traumatic events and its meaning if the client's able to recall the event. And a lot of that, the deep part of that, is the therapist does it. Like I know when I worked behavioral health at Le Bonheur on the child and adolescent unit, Dr. Mosley would say, today I don't want y'all to even, get too deep in this, because if they do, the patient's gonna escalate. And let's make sure that we have the staff ready when they escalate. Because when they escalate, they sometimes start to be aggressive and act out. So you want to, it's not everybody's place to get to that deep traumatic, especially if it's subconscious. The therapist or psychiatrist is gonna do that, and the nurses are just ready. Like a charge nurse on the unit is gonna make sure the milieu therapists are ready, that if they think they may have to go to the safe room, on the mental health unit, they have safe rooms for the pediatric adolescent patients. They don't look real safe. They're like a concrete room with a window on them, and you've got somebody sitting there constantly watching them. And if you get to go to the child and adolescent unit, I'll take you and tour you on that. Some of you got to tour last week of that, and people were a little afraid to go in there, and after they did, it was on the Bridges side. That's the more violent kids and things. But the kids on the child side also get put over there. And the nurse and supervisor there has to, within an hour, has to assess the child, or the hospital's in big trouble, to make sure the child really needed to be there. Because I think on your last test you had a question about whether or not what would happen if you put them in restraints and they shouldn't be there. So the client often remains hyper alert. They may have discomfort with physical closeness, and they may appear anxious or agitated. So they become dysfunctional many times, and so they do need counseling, and they do need help, and they do need the support of family and friends. And hopefully they're in a workplace that has EAP, y'all know what I'm talking about. A lot of jobs have EAP, and they provide free counseling for so many times. And a lot of insurances have separate insurance for mental health than they do for physical. And, people are becoming more aware of mental health, and, when you, jobs will provide the EAP. So you need to look, when you look for a job, make sure they do have that, in case, you never know, something could happen in your family that you're not expecting. I mean, even like divorce, that kind of stuff, they will provide counseling for EAP. They're all different. They just do a certain number. You might have a child that's depressed, all those kinds of things. But, our society is getting better about accepting mental illness. For a long time, people just thought, well, they remembered the places, the psych hospitals where people were institutionalized. But now, we realize that anybody, given the circumstances, can need mental health counseling, right? It can happen to anybody. It can be somebody in your family is addicted. Well, y'all learn if you go to the 12 steps that the whole that everybody in the family is, becomes sick, because the family members may be enabling and like obsessed with trying to get that person to stop, using drugs or alcohol. And so they become sick because they become focused on that instead of being functional. So, so trauma and stressor related, the mood and affect, you know, you look to see whether they're passive to angry, frightened, agitated, whether they're hostile. And the thought process, are they experiencing nightmares and flashbacks and intrusive thoughts and hallucinations and self-destructive thoughts and fantasies? So an intrusive thought, sometimes they're trying really hard not to be depressed, and they might just have a thought, you might as well just kill yourself, that kind of stuff. And then sensorium and intellectual processes, they're oriented to reality except during flashbacks. So you may think they're fine, and then maybe they don't tell the person they're dating or something that they're having flashbacks, but they really are. And they don't want anybody to know about it because they don't want them to think they're mentally ill. And then they may have memory gaps, and then intrusive thoughts and ideas of self-harm. So trauma and stressor related assessment, judgment and insight, they may report a little idea of relationship between trauma and symptoms. They may not really realize what that was causing them to not participate like they normally did, or not be as functional as they were. And others may know exactly what's going on, and they may try to keep it from people, and then, but their decision-making ability may be impaired just because of all the stress of what has happened to them. And it may cause them to have a low self-esteem, and they may just feel like, I'm worthless, why go on, I'm never gonna get better, these thoughts are never gonna stop. And then they may have problems with authority, they may get angry, they may lash out, and then close relationships may be difficult or impossible. So, you know, divorces may occur, that kind of thing. Okay, so with trauma and stressor-related assessment, some of the things you're gonna find out, and a lot of our patients at Lakeside have had difficulty sleeping, that's been one of the things. And then they may have a change in appetite, and then they may have turned to alcohol and drug use just to numb the pain. And people don't ever mean to get addicted, right? They just think maybe smoking some pot or doing something will help numb that pain. And you know, the experts say that if somebody has a history of mental illness in their family, smoking pot one time can cause those chemicals to cause that to exacerbate. Doesn't happen to everybody, but people that have a strong history of mental illness, it's out there, it can. And they've had it happen, they know for sure that that's true. So data analysis and priorities, common problems, of course, it's gonna be risk of suicide and self-mutilation. That's why they don't give pencils to patients if they think that they're at risk of hurting themselves. There's so many ways psych patients figure out how to hurt themselves. That's why they usually take their shoestrings or their shoes when they go into the facility, because they can tie those strings together and hang themselves. If they have they try not to ever have a room like with a little sprinkler in it, because they will try to hang themselves from things like that in the room. They can find anything. You know, the plastic forks and spoons we don't throw away where they can get to them, because they can actually make a ligature out of them and hang themselves with that. You know, the little tennis shoes with the little lights that flash, like kids wear, they can take those coils out and do all kinds of stuff with that. They can take t-shirts and strip them, cut them in strips and make a ligature out of it. So you have to constantly, you know, be observant of the inpatient, but then when they go home, you don't have control over that. So, you know, hopefully they're at a point when they go home that they're no longer suicidal, because they can't discharge them if they're still suicidal. They have to put them somewhere else, because a psychiatrist is legally liable if they discharge somebody who's homicidal or suicidal, actively homicidal or suicidal. and then just generally ineffective coping, and then just overwhelming stress and emotions, where they feel overwhelmed, they just can't go on. And then they may have difficulty because, they may lash out in anger because that's, the easiest thing for them to do. And then chronic low self-esteem, and then they may feel helpless and have feelings of hopelessness. So long-term problems, disturbed sleep patterns, sexual dysfunction, social isolation, and then not eating, or sometimes overeating. So, they may do stress eating, or they may just not eat. And then, before they go home, you wanna make sure that they're gonna be physically safe, that they have the ability to distinguish self-harm ideas from actions, and that they can demonstrate healthy, effective stress management. Now, some of that's not gonna happen before they go home, but if they do intensive outpatient, then they may be able to continue, or they still have a therapist. And then non-destructive, expression of their emotions, where that they can, go, hit pillows, or have a boxing bag in there somewhere where that they have some way, instead of hitting somebody else, that what they would do. So they teach them coping mechanisms to, when they do have those thoughts, or that they can, stop, and they have some that you just stop and don't let the thought come. And then, of course, a strong support system. So you want to, it's just kind of a way for you to remember, discuss self-harm thoughts with the patient, help them develop a plan for going to a safe place, and using grounding techniques, validate the client's fears but increase contact with reality, and then use supportive touch. Sometimes you'll see the therapist, as students, we try not to put any hands on it, but sometimes a therapist can, maybe put their hand on their shoulder or something. Teach deep breathing and relaxation. You'll hear a lot of the kids talk about the deep breathing and relaxation. Another thing they use is the butterfly hug, and this they teach to all the patients. I don't know if y'all heard this in any of the group, and it's like opposite sides of your brain. You can't think a bad thought. Like you can even, like if you're having a test and you're nervous, y'all can do this, or you can do it on your legs where it's not so obvious. But it's got to be opposite tapping. Had trouble going to sleep, can do that, because it's hard to think when you're doing opposite. Something about the opposite sides of the brain. And so you can Google it. It's butterfly hug, and it tells you all about it. And then teach distraction techniques. How to make that thought. Don't let that thought enter. And refer to your client as a survivor, not a victim, and then establish a social support system in the community. So grounding techniques are helpful with disassociation or flashback. And what that means, you remind the person that they're in the present, they're an adult, and they're safe. And you want to increase their contact with reality and try to diminish the dissociative experience by focusing on current experiences, like, tell me about your job, tell me about your family. And then, just try to get them to focus on what's going on in the present. And then self-awareness issues, you have to deal with your own personal feelings about traumatic events, abuse, and natural disasters. Because if you have something happen in your life, it may be hard for you to work with some patients. And then convey empathy, and then remain non-judgmental, and that we've got to always never act surprised, no matter what a patient tells us. And you've got to always put your own biases aside in dealing with your patient. Okay, the following statement, true or false: persons who witness a traumatic event are likely to develop PTSD.
True.
Not all people, nor even most people, develop it, but the most likely are those who are directly involved in the event, not just merely a witness. Those who experience physical injury or loss of a loved one, those with lack of social support, or those with previous psychiatric history, repeated trauma. So some people are going to be more likely, based on their background and their other experiences to develop it. But it's, it's nothing shameful if somebody develops it. They just need to get the help they need so that they can go on and live their life. And then question 2, which person is most likely to experience a dissociative disorder?
B.
Kids with history of childhood physical or sexual abuse, and dissociative disorders are relatively rare in the general population. Okay, is the following true or false? It may require years for clients to experience trauma to achieve their outcome. Some do better than others, depending on their support system. Okay, y'all okay? Keep going. Let me know when y'all need a break. Anybody want to come get a cupcake? Welcome to come get a cupcake. You didn't sign in. Check your name here. Okay, going. We're going to talk about anxiety and anxiety disorders. And we all have some anxiety, right? We get anxious if we're going to take a test. We get anxious if we have to do something we're not prepared to do. We don't feel like we have good instructions. We get anxious if we think we're not going to pass our nursing course. If we're not going to pass NCLEX, all this money, and I've got to pass NCLEX, and we want all y'all to pass NCLEX. That's why I'm making y'all do the ATI remediation. That way, when you, in your other course, you understand better how to remediate. I really meant for y'all to do the 2024, but some did the 2019. I didn't even know it was open. Dr. Gibson must have opened them all at some point because I didn't even know 2019 was open. I closed the B on 2019, so y'all would at least, if you've already done the other one, whatever you did your remediation on, I'm gonna accept. But the difference is the 24 has more next gen questions, which is gonna prepare you better for the new NCLEX, and that was one. So, and I believe the ATI that y'all take that will pop up will be the proctor one will be 2024, that's fine. So if you, after you finish both of them, if you want me to open up 2019 for just more practice, I can, but, and I need to put some dates when they're due. I wasn't so worried that they, as long as y'all did it, you know what I mean? Because I want y'all to really get into it and do it right. So I will put some, the second one will be due before your last proctored one. Now you do have to do remediation on your proctored one, but that grade comes out differently. That grade comes out on the part that's ATI. So that one comes out. So instead of pop quizzes, I've given you that ATI remediation. So if you remediated on everything you missed, I have to go back in and check each one, and then put your points. Did I tell you 3 points or 4? Did I tell you 3? 4, yeah. 4 points on each one, then you'll get 100 on it. So it's actually better than a pop quiz, because if you do your, the stuff in the points, the prepu, and you do all that, that'll just be an automatic 100 under quizzes. So that does help people's grades. So I know it's a lot of work, but I'm really helping you by doing that. So, okay? So, if I gave you a pop quiz and you weren't here, it's a 0, right? So, that kind of stuff. So, and I don't, and I really just think it's more valuable, to do the API. And last time, I had 35 students, and I think only 2 did make a level 2 or 3. We had quite a few level 3. So, and it was the first time some of them had ever done that, and took remediation. And they said they wish they had known all the way through about remediation. So, some of the other faculty are starting it now, since I kind of shared with them. I've been using ATI for 15 years, because that's what we used at Union University. So, I'm pretty familiar with how ATI works. And I do have a study sheet for ATI. It's not based on the test itself, but just basically what I know that just given tests all these years, and standardized tests with on it, and I will open that up for y'all too. It's just stuff for y'all to look up and know, okay? So, learning objectives, just remember, these are things that, are part of your, continue to know. So, y'all know what anxiety is, and sometimes it's just kind of a vague feeling you're kind of dreading something, and you feel anxious, right? And then that's different from fear. Feeling afraid or threatened by something is different than, anxious. And then anxiety disorders share the key feature of excessive anxiety with behavioral, emotional, cognitive, and physiological responses. And it causes stress, wear, tear that on the body. So it is a response to stress. And this is all from your book. Anxiety is a response to stress. So generally, you have, physiological aspects of stress. Selye, y'all remember studying about him, and he had to take, y'all did take some kind of psych stuff, didn't you? Psychology, y'all had to take that. Alarm reaction, preparation for defense. And then resistance, the blood shunted to areas needed for defense. People can lift up cars when they never could do that kind of thing. Exhaustion stage, body stores are depleted, emotional components are unresolved. And that's when you start to see chronic problems and people needing counseling and people needing medication. And then mild stress is sensing something is different, requiring special attention, increased sensory stimulation, motivational. So a little bit of stress can be good, right?
Mm-hmm.
If you know you need a little bit of stress so you do what you're supposed to do. And then moderate is feeling something is definitely wrong, nervousness, agitation, difficulty, concentrating, but a lot of times you can still redirect that. So severe is trouble thinking and reasoning, tightened muscles, increased vital signs, restless, irritable, angry, maybe can't sleep. And then panic attacks, panic is fight, flight, or freeze. With increased vital signs, enlarged pupils, cognitive processes are just focusing on the defense. And so anxiety, mild, associated with tension of everyday life. Person is alert, perceptual field is increased, learning is facilitated. So with this one, this is like you're studying for a test. It's okay to have a little bit of mild anxiety. Affect could be positive, I know I'm gonna pass this test because I'm studying hard. And then anxiety focus is on immediate concerns. The perceptual field is narrowed. Low level sympathetic nervous system arousal, increased pulse, respiration, tension and fear are experienced. And you don't want to have moderate stress when you are taking a test, because you might have trouble focusing, if you're doing that. So you want to do some relaxation techniques. Sometimes I'll tell a joke before the test. I don't think I've done this for y'all, but I'm not a good joke teller. My husband's a wonderful joke teller. And so, one time, when I was the educator for all the school nurses, when the city put nurses in the school for the first time in 20 years, it was late 90s. Yeah, I was the educator for all of them. We went to all the schools and blitzed the city with CPR and teaching. They didn't have one nurse per school that year. They still had 5 or 10 schools, I can't remember now, but each. But, so because I was the educator, I had a full office at Le Bonheur, so it was the Board of Education and Le Bonheur had a joint thing going. I think Le Bonheur paid the benefits and the Board of Education paid our salary, I think, I don't know. But I never knew, I just got the check from Le Bonheur, but anyway, so they would call me when like kids had head lice or if they needed some extra teaching. And one time, school off at Chelsea, I had to go teach all the maintenance men, something, and so I asked my husband for a joke, and I was so afraid I would mess it up that I did a PowerPoint with the joke, so I didn't mess up a lot. But I have one that he gave me that I don't mess up on, and it's real easy. So, did you know that diarrhea is hereditary?
No.
It runs in your genes.
Oh.
So that, sometimes I
Oh.
tell little things like that before the test to kind of help students relax, especially when I just taught diarrhea in pediatrics, you know, that was one of the And, but I actually had one student one time, from Northwest. I remember cause I used to do clinical at Le Bonheur for Northwest, U of M, Southwest when I was teaching for Methodist, so. And she goes, really? I didn't know that. And I thought, oh Lord, it's gonna be a hard term. And so anyway, so that does kind of, you know, making people laugh can kind of decrease their anxiety a little bit. So, and then severe anxiety, I mean, that's where they're like watching out the window, they're worried that they're hypervigilant, their perceptual field's reduced, they can't really learn, their sympathetic nervous system is aroused, severe emotional distress is experienced. And those are the people that you actually, you know, it's not a medical term to say somebody had a nervous breakdown, but that's a lay term, right?
Mm-hmm.
And you know, what does that really mean? It probably just means they reached the point they had to be hospitalized.
Mm-hmm.
And so, and then panic, we've all heard about people that have panic disorders, right? Where they actually, their heart rate starts going up, they start having chest pain, they just have overwhelming emotions, and it can cause regression to primitive or childlike behaviors. And so, working with anxious clients, we have to be aware of what their anxiety level is, and assessment, you know, it's a nursing assessment. You use short, simple, easy to understand sentences, because when somebody's really stressed, I mean, you know, when we go in the hospital and they do discharge education in the ER, and people have had, you know, no sleep, they've been in the ER all night, and then we give, and then somebody can say da-da-da-da-da and hands in the papers. They don't get it, do they?
Mm-mm.
So it's best to at least tell them the simple things, you know. It's important that you call the doctor for an appointment when you get home, because if you wait for 2 weeks, you probably won't get in, you know, that kind of thing. Just tell them the simple stuff, and then, I mean, how many of y'all had gotten education that somebody just said, here, this is your discharge instructions, and you're thinking, what?
Yeah.
You know, that's
That's
how
happened.
to do it. But I love it when student nurses go in and do, like, go over their medications and stuff when they discharge a patient. I always had my students at Le Bonheur just do the discharges, even if the nurse was in there or I was in there. And I would, and it was so neat, because they wouldn't know any of these, and then they would go look them up, and then they would just be in there like acting like, you know, fake it till you know it kind of thing, you know. I was always so proud of them, because that's what you kind of have to do as a nurse sometimes, right? If you don't really know everything about that particular diagnosis and you have all these handouts, you need to get familiar with them, but then you want to be confident when you go in and talk to your patient. You at least want them to feel like you know what you're doing. And then use of short, simple, easy to understand sentences, like I said. Okay, lower person's anxiety level to moderate or mild before proceeding. So you want them to, you know, kind of calm them down, low, calm, soothing voice. I don't know if I told this group, but I told you as a house supervisor at Le Bonheur, I was the one on weekends and nights that always had to go talk to angry parents. And sometimes they were angry at the doctor, sometimes at the nurse. And I found that if I took them, offered them a cold drink from the floor, you know, they always had something like Gatorade or Coke or something on the floor. And I would take a little puppet or finger puppet or something to kind of calm with the child and kind of entertain them. And then I would sit down and look them, and you know, and I would say, I'm so sorry you're having a bad experience. I didn't necessarily think they were having a bad experience, but from their perception they were. And so just remember, when you're dealing with people, perception is more important than reality.
Mm.
And then you know, you make them feel like they're the most important in the world, and you do go follow up on whatever they told you. It might be that the nurse or doctor really hadn't done anything, or it might be they had, I mean, one time I got called because they told the nurse that their, the TPN, the highbrow, they changed the ingredients every day. And they had changed, and the nurse said, no, this is right, and the nurse was wrong. So sometimes, I tell my students to check TPN every ingredient when it changes shift. I know when I worked at Children's in Dayton, we had to literally change a shift, stand there and go through. Y'all know what I'm talking about? TPN, it's got all kinds of vitamins and different percentages, and people just say, oh, it was hung. But if one of those ingredients is wrong, you're gonna be liable. So you need to check those ingredients, and it really should be done at turnover, shift to shift, and when they go room to room, but it doesn't always get done. And that's your mistake if you let it hang your whole shift, and that's why I, tell students they should always check the IVs the minute they walk in, because it's on you if the wrong thing is hanging. So back to this. In panic, safety is a primary concern. So, they may use, I think I've got table 14. Oh, I didn't have table 14 here. It's in your book. Y'all can look at it. I'm sure it's, and then, so some of that, there are agoraphobia, panic disorder, specific phobia. These are the different ones.
Which one's gonna be on the test?
Huh? It's in your PowerPoint, table 14 too.
Are you gonna have all these on the test?
The anxiety disorder.
All the anxiety.
Oh, the one you just had, the one.
It's so beautifully
It'll
wrapped.
be general on the anxiety, yeah. I mean, if I talk about it specifically, it'll be specific.
That one.
Yes. Yeah. So, but, panic disorder, y'all need to know about what happens with it. And, social anxiety is where they have a social phobia, where they, maybe an adolescent won't talk to the other kids at school, or they're afraid to at lunch, they may eat by themselves because they're afraid that they're gonna be rejected, probably because they have been rejected sometimes, or bullied. And then, so anxiety disorders, highest prevalence, rates of all mental disorders in the US. So more prevalent in women, more prevalent in people under 45, and, related disorders, not able to talk, they freeze, anxiety disorder due to another mental condition, substance medication induced anxiety disorder, some medicines can cause, increased heart rate risk and all that. Separation anxiety. So the biological theories, again, the medicines we give, are gonna affect the GABA and serotonin. And then, we've already talked about all the psychoanalytic theories and Sullivan and Tableau and behavioral theories. So cultural considerations, each culture has rules for expressing and dealing with anxiety. Some cultures, anxiety is expressed through like headaches, backaches, fatigue, dizziness, and stomach problems. Some cultures feel like it's disgraceful to have an illness, much less a mental illness, and so, other cultures view anxiety symptoms as caused by supernatural spirits or bad air. They think that somebody is like demon possessed or, something like that. Important for the nurse to practice cultural humility, being aware of cultural differences. And we can't talk about that enough, because we can't stereotype that, everybody who's Asian does this, because that isn't true. It's just like all of us. We may not do everything the same. And, so we have to be really careful about not stereotyping patients. And then treatment, combination of medications and therapy or antidepressants, and they'll do the cognitive behavioral therapy, where they do reframing, where they turn negative messages into positive ones. They teach them how to do that. And the catastrophizing, making more realistic appraisal of the situation, like what's really going on here? Tell me what's really, is this gonna matter tomorrow? Is this gonna matter an hour from now? Is this gonna matter a year from now? And then assertiveness training, learning to negotiate interpersonal situations so that they're not so, intimidated by others. And then, children, they just may freeze and can't say anything, separation anxiety, social anxiety, can persist into adulthood. Late life anxiety, the agoraphobia, and panic attacks are less common, often related to other illness. They may go back over and over things they did that they could have done differently. That if they had done something differently, their marriage might have been better, their children might have turned out better, that kind of stuff. They just, going back and regret. And with those, they usually give SSRI uptake inhibitors and antidepressants. So, and we know if somebody has anxiety, that they may not be dealing with stress. And positive events can be stressful as well, like weddings and that kind of thing, right? People get really stressed now because there's so many things they have to have, all this extra stuff for engagement and, pictures and all that. And managing effects of stress and anxiety is going to be, of course, important. And the goal is effective management and not the total elimination of anxiety. We don't want to totally eliminate anxiety, right? We want, because a little bit of anxiety helps us do what we're supposed to do. And you think, I don't have to study for the test, I'll just go out and have a good time tonight for the test, and that's not good. So, although medication is important, it does not solve or eliminate the problem entirely. So, they will put them on meds, and we know that most of the meds are gonna take about at least 4 weeks to start to be effective. But, medication doesn't solve everything. They still have to deal with their issues and their thoughts and all of those things. It just helps them be able to do that. And then, so when you're talking to your patient, you want to give them some tips for managing stress. You want to help them accept lack of control, assertiveness communication, expression of feelings, talking, laughing, crying, help them relaxation techniques. There's a lot of different things they can do. There's music, there's videos and tapes they can listen to help them relax, and then just deep breathing exercises, maybe yoga, and then realistic goals, personally meaningful activity, help them find things that are meaningful in life that help them to relax. Sometimes it's hobbies, or it could be cooking or baking, or like baseball, or going and hitting the baseball, or whatever, or maybe being on a team, learning to relax. So realistic goals, well-balanced diet, and we know diet makes a difference in how people and their health, right? So if people eat right, they get the right vitamins and minerals, and they're likely to help their chemicals in their body. And then intake of caffeine and alcohol. We have to limit that. If somebody's already nervous, caffeine's gonna make it worse, right? And then alcohol is gonna make them more depressed in the long run. And then if they get addicted to it, it's gonna really be a problem. And then, they learn exercise can be one thing, and the use of stress management techniques. Some of y'all in your groups may have gotten to do yoga or exercise with your patients, and I think they did some on child and adolescent and some on the addictive unit. So then the panic disorder, discrete episodes of panic attacks, no stimulus for it. It just all of a sudden comes on. And the disorder is diagnosed when recurrent unexpected attacks followed by at least 1 month of concern and worry about future attacks. And agoraphobia is one a lot of them have. Increased risk of being suicidal, avoidance behavior, and then primary and secondary gain. Whether or not this is going to help them or not. So it's going to be real important that you teach them deep breathing relaxation technique, and then SSRIs, your tricyclic antidepressants, and your antihypertensives. Okay, so the Hamilton rating scale is in, I did put this in your thing, I thought I did, I just didn't put it where I thought I had. So, history, you get a good history on them, you, just look at their appearance, their motor behavior, you know, if they're tapping, that kind of stuff, mood and affect, if they have depersonalization or derealization, thought processes, whether they seem like they're disorganized thoughts, that they're not making sense, if they seem like they don't have rational thinking. And these are the, this is what your book has, some of the signs of the physiological responses. With mild, they may just, you know, have stomach a little upset, trouble sleeping, restlessness. But moderate, that's where they may have headache, they may talk faster, GI upset, going to the bathroom constantly, muscle tension. And then severe, you're gonna see headaches, nausea, vomiting, diarrhea, trembling, real rigid, vertigo, pale, tachycardic, they may say they have chest pain. And then your panic, maybe they may bolt and run or totally immobile and mute. They don't talk. And dilated pupils, increased blood pressure, pulse, fight, flutter. And those are your panic attacks. And sometimes they give them something they can put under their tongue. Like, I think they have a quick acting Xanax that they can, like, or so much of Ativan that they can take right then to kind of try to calm them. You want to see if they're confused, if they're disoriented, and how do you think you can test judgment? How can you tell if they have poor judgment?
By asking them questions, just seeing how they respond.
Right. And, you know, see if they've gone out and done something crazy, then maybe they got trouble with the police, or the family was upset with them and even had to put in the hospital. They may blame themselves, they may just be consumed with worry, and then they avoid others, and then their sleeping and eating issues. So with this, some of the nursing diagnosis would be related to anxiety or fear or ineffective individual coping. They may feel powerless, social isolation, spiritual distress. And so they have their thoughts, am I really in danger? And then they feel the body senses coming up, and then they get into, oh, something awful is gonna happen to me, and they feel anxious. Sometimes they won't even go out of the house. You know, these are the people that just stay home, they won't. You've heard of people like that they got so anxious they wouldn't leave the house for anything, they wouldn't go to the store. And then coping strategies, that little stress ball. Every time I go to nursing conferences, they always have tables with those little stress balls on them.
I should tell you something more.
So breathing exercises, guided imagery, that's where you can say, and you can do this on a small level. It doesn't have to be a great big one. Like if you have a patient that's anxious, and they like to fish, you can say, imagine yourself, close your eyes, imagine yourself on the bank of the river and see the ripples of the water and feel the cool breeze on your face, and you know, something like that. Or find out whatever their hobby is and what brings them like peace. And or maybe they like to go to the beach, and you can, you know, just say, you know, feel the cool air from the beach and take some deep breaths and breathe in the air and see the waves and the tide coming in and out, you know, and just kind of talk them through. That's kind of what guided imagery is. It could be listening to music. Some people do listening to music helps them. Some people, and you see them do all these things at Lakeside and other mental health facilities because they're trying to get what's good for everybody. And then, you know, physical exercise gets their mind off of whatever and helps them. And also helps their endorphins and all that. And then, of course, your pharmacology, and then your individual and group therapy. Okay, so dealing with anxiety, you know, the nurse is gonna And y'all are doing this at Lakeside, some of you are through with this, where you, you do your assessment, your mental health assessment, and then you form your nursing diagnosis and think about a short-term goal and a long-term goal. And then all the time, you've got to promote safety and use therapeutic communication. And, that's what I told you. That's one of the things I wanted you to get out of mental health because you'll be dealing with patients all your whole career. And then managing anxiety and then providing time and family education. If the person is going back home and their family is involved in their care, they're gonna do some family therapy where they bring in, if it's an adolescent, they're gonna bring in the parents, and if it's an adult, they may bring in a significant other, or if they're living at home, it may be their parents if they're in their guardianship, and they will do family counseling, and sometimes a lot comes out in those family counseling sessions because, they'll get angry, they'll lash out at somebody, and you'll realize there's something else going on sometimes that they haven't told you about. And then, of course, evaluation, and it's like nursing process is cyclic. You see if that's working. If it's not, you try something else. Same thing with medications. The doctors do that. And then phobias are intense, illogical, persistent fear of something. Some people are fearful of heights. Some people, you're fearful of heights.
I look at it on TV, somebody's up high, and I feel like I'm with them.
And I bet you don't fly then, do you?
I've never flown,
Oh,
and I wanna be a travel nurse.
Oh, no. So response is out of proportion to the situation or circumstance. And it can be agoraphobia, specific phobia, social anxiety, or another phobia. And categories can be natural environment, there may be blood, injections, some people are afraid of needles, situational, some people are afraid of dogs or other animals, and other specific, types. And so, treatment, behavior, spiders, might be afraid of spiders. And then the positive reframing, the assertiveness training, systematic desensitization, and then flooding. And then medication, these are some of those, and, I've given you handouts on these, medications, but, so medications will be on this test also. So, self-awareness issues, nurses need to understand what and how anxiety behaviors work, that's why you're doing this course. But nurses are also vulnerable to stress and anxiety. I've had student nurses, not because of me, but other reasons, that had to drop out because they were having severe anxiety. It could be, related to maybe an engagement breakup, or get your cup. Okay. Related to, your name? So, using techniques to manage stress and anxiety in their personal lives. And of course, we can't fix somebody else's problem. We have to learn we can't control anybody but ourselves, right? And when y'all went to AA and NA type groups, you learn that nobody can control the person has to control their own behavior. And so it's the same thing with you. You might have somebody trying to control your behavior, but really, you're the only one that can. And so, all those techniques we've talked about, exercise and eating right and talking to somebody and hobbies, whatever. Sometimes we get so busy we don't think we have time for exercise or to eat right, but actually it's not good when you do that, right? We're making ourselves worse. And then, is the following statement true or false? Anxiety and fear are considered to be two different things.
True. True.
Is the following true or false? The neurotransmitter dopamine is associated with anxiety disorder. It's GABA and serotonin. Which finding would a nurse expect to assess in a client with a panic disorder?
Somebody said
Yeah, the tapping and all that. or false? Phobias result from a past negative experience.
False.
Right. They usually do not result from past negative. In fact, the person may never have had a contact with the object with a phobia.
Until you find out you was scared.
Okay, y'all take I'll let y'all take about a 15-minute break, okay? You were doing really well, and at the end today, we're gonna go over the test, so.
Everybody, or you just gonna call us up individually?
Everybody, yeah, I don't, 65 students, now, if somebody names below 78, they need to meet.
Hey, what's going on, Professor? How you doing, man? That was because I was trying to pronounce it. Oh, is it E? I was trying to do it.
You go. I'll let you know what's going on, okay?
Having, and one would be, an example would be like, when I was house supervisor, she's not doing this anymore, I mean, she doesn't work there anymore, but, she would always come in and she thought my paper that I passed on wasn't neat enough, she'd rewrite it, you know?
Rewrite it?
Yeah, she'd rewrite everything, cause she had to have it just perfect, and I would just make sure I got the information. You know? And where you could read it, I mean, you could read it, I'd print it, but it wasn't perfect enough for her, and she would, and I'd say, what, you always redoes mine, are you kidding me? But it wasn't my problem, she was the one that had the problem. I thought, well, how did she get all her work done? And she's always rewriting everything, but, you know, I know she had a problem. But anyway, but she could function otherwise, you know what I mean? But having aggressive urges can be one too, people that have those compulsions. But the hand washing is the one we talk about the most usually. And obsessive compulsive is diagnosed once thoughts or behaviors consume the person to the point where the thoughts or actions interfere with their personal, social, or occupational functioning. Some people are OCD and they function just fine. I mean, you may recopy all your notes, but I would just tell you, as long as you can read them, unless it helps you remember them, probably wasting your time. So that's just big, you know, but sometimes I used to retype mine because I couldn't, you know, it helped me because I could study it better, but you have to do what works for you, as long as it's not interfering with your life. The person realizes that the thoughts, behaviors are unreasonable, but they can't stop or control them. They can start in early childhood, and females more commonly begin in the 20s, periods of waxing and waning. Sometimes they do better than other times. Differences in early onset and late onset, OCD, we'll talk about those. And some people, it can even be everything in their house has to be perfect. You know, all they have to do is go to nursing school and they'll get over that, right? No, they won't get over it?
Oh, shit.
Okay.
A little bit.
But you can still function.
I try to keep it clean, but my kids.
Yeah, I mean, you get to a point that you can't sometimes, you know, if it's just you might be able to keep things neat, but when you start getting other people, it gets hard. So you have to kind of let go of some stuff, or get a housekeeper. But related compulsive disorders, self-soothing behaviors, they may pick at their skin. Sometimes you'll see our citations, they may pull their hair. We've had kids that with hair pulling, nail biting, you know, people that bite their nails, body dysmorphic syndrome, and hoarding. Hoarding is also a compulsive disorder, and you've seen people that are pathological with hoarding, right? You see that. Have y'all ever watched those hoarding shows on TV?
Mm-hmm.
And it's not just like you like to collect something, you have a whole bunch of them and they're organized. That's not what hoarding is. I'm just laughing because I have like color-coded boxes of holiday stuff. I decorate for every holiday. So, but mine is not hoarding, mine is organized. They needed stuff for the Super Bowl party.
That's what they all say.
They needed stuff for the Super Bowl party. We hadn't used it in 15 years, and I had it in nice, neat blue boxes, all my stuff. And they couldn't believe I had all this stuff. But I also have a basement, so I have a lot of places to store stuff. But hoarding is like, you know, where it's the stuff is not even useful to you. It's like they'll throw paper, like potato chip wrappers and
They
food.
think it's useful to them.
It's there for, you know what I mean? They don't ever clean it up. They don't. Those are like pathological hoarders. You've seen it on TV. They'll have somebody come in and they try to help them organize their stuff, and they won't let them throw stuff away. You know, they're really sick.
So like with people with OCD and hoarding and stuff like that, when things are not going the way they want it, do they have like side effects like depression? Do they get depressed because it's not?
Or they can't function.
Mm-hmm.
Yeah, they just lay in bed and they can't function. I mean, I worked with somebody that her grown daughter who lived with her had gone through a divorce, had a child, and they lived in her house. But her room, she said, she had to make her move out eventually because she'd have just trash in her room, and just she wouldn't clean up and wouldn't throw anything away. And so you know, some people in home health nursing have gone in homes that were like that, and it's not clean or safe. You know, I mean, sometimes I heard of somebody that this person told me I would never be invited to her house because knew she had a problem, and she said that she even stored stuff inside her oven. And
That's a psychiatric.
yeah.
That's why the psychiatric people come first before the cleaning people come. Yeah, on TV.
Oh yeah, they do, don't
The
they?
psychiatric people come
Yeah,
first.
yeah.
Because it
I
don't matter
can't
if
stand
you
to watch
clean it.
those. They just but anyway, and then kleptomania is compulsive stealing. People that they're stealing for no reason. I mean, they're like at Marshall's or somewhere, and they're stealing. They don't even need it. They may have an expensive purse on their shoulder, and they're putting another one on their shoulder, walking out the door, or they just can't help it. And then but you know, the law doesn't say that's okay just because they have that disorder. And then compulsive buying, they just can't stop shopping. And whether it's online or actually in the store, even though they don't need it, they still buy it, right? And so, or they just can't, they spend more money than they have, or they have price tags still on everything in their closet, and that kind of thing. Body identity integrity disorder, where they just feel like, you know, that they're either too fat or It's not quite the same as anorexia.
Is it like the dysmorphia, is that?
Yeah, more like that. So etiology of OCD and related disorders, is based on Ehrenbeck's cognitive model. It focuses on childhood and environmental experiences growing up. In heredity, there are a complex network of several genes that can contribute. So there is a genetic component of OCD, but it, doesn't always run in families. Cultural considerations, variation in expression or beliefs about symptoms. Highly religious individuals, both Christian and Muslim, may have heightened sense of personal guilt, so they may feel guilty about something. And so in some cultures, patients with OCD believe in a supernatural cause, and pharmacological treatment varies a great deal. So somebody might feel guilty about something and they wash their hands over and over. Like in Shakespeare when there's something about hand washing. I don't know, but anyway. Combination of medications and therapy. First line are going to be your SSRIs, and then your second line would be your serotonin norepinephrine uptake inhibitors, and then your treatment-resistant OCD would be your second generation antipsychotics. We saw a lot of these this weekend on the child unit with risperidone and aripiprazole. Treatment, behavioral therapy, deliberately confronting the situation and stimuli that client usually tries to avoid. And then they may help them learn to delay or avoid performing the ritual, learn to tolerate the thoughts and anxiety. So they go through therapy where they can deliberately confront them with whatever it is that they're worried about. See, that this is just, they're doing this to relieve their anxiety, so they have to find out what they're really anxious about. And then, so the nursing process, there's a screening tool, I don't think I put it in here. But it's 15.1 in your book where you can use it. Stats, history, you look at their general appearance, and usually somebody that's OCD is real neat. They look almost like they're starched all the time. And so mood and affect, and they may have overwhelming anxiety, and then they may describe their obsessions as just rising out of nowhere all of a sudden. And then judgment and insight recognizes obsessions as irrational, but they can't stop them. They know it's stupid that they have to rewrite everything 10 times until it looks perfect if they make a mistake. Self-concept, powerlessness, low self-esteem. It affects roles and relationships because they get so focused on whatever their obsession is. It could be folding clothes. I heard about somebody that would open all their drawers. Somebody told me their wife did this when I was teaching something, that they would open all the drawers every day and refold stuff if it wasn't perfectly folded after they did the wash and stuff. Everything in the drawer had to be perfectly neat. And, it's okay if you have time, right?
Yeah, sure.
So, but anyway, physiological and self-care considerations, sleeping problems, appetite problems, weight changes. They may have compulsions for eating that's a little bit different than your anorexia. So common problems, you're gonna have anxiety, ineffective coping, fatigue. They get tired because they're redoing everything so much, they just wear themselves out. Or they run back and forth in the house and see if the iron's plugged in, or if the door's locked, and all those. Low self-esteem, and then they can even get skin breakdown for nervousness, like kicking their skin. And actions, of course, using therapeutic communication, relaxation techniques, behavioral techniques, and then just the daily routine completion without going back and redoing everything. They help them learn that while they're in therapy. And then client and family education, helping them with their stressors, and then evaluation to see if it's working, and if it's not, they start over again. So teaching, teach the family about it. you know, tell them they need to talk about their anxiety, find somebody they can talk to, and emphasize the importance of being compliant with their medication. And you think this, somebody with OCD is probably more likely to be compliant with their medication, right? Because they wanna make sure they do it every day. And then, tolerating anxiety, you know, whatever is causing their anxiety, helping them with anxiety itself. And you wanna teach families not to always give advice, because that doesn't help them. And then teach them to avoid trying to fix the problem. You know, they can't just go in and take the soap away, so they can't wash their hands. Just like you can't take drugs away, they're gonna get them one way or the other. And then patience, monitoring anxiety levels among family members. If family members are anxious, it may make this person more anxious. And then, you know, just give them let them take some breaks. It's okay not to be perfect if you're OCD, you know, let them realize that sometimes they're going to kind of relapse too, and when they're really stressed, they may start whatever ritual it is. But to a certain extent, there's like, autistic kids are like that. If you change one thing, they're real OCD. You change, we'll talk about autism the last week, but, or I think it's the last week, but, if you change one thing, like if they normally brush their teeth, have a bedtime story, say their prayers, and drink of water, if you get one thing out of order, they get all upset, they just go ballistic. So, and then self-awareness, they need to understand, the family does, that the client can't just simply stop it, they can't just stop it. It's a chronic condition, and they already know the thoughts and rituals are gonna interfere with their life. Because they're spending so much time with this ritual, they're not doing other things they should be doing. So, okay, is the following statement true or false? OCD can be manifested through many behaviors, all of which are repetitive and meaningless.
It's true. It's not meaningless to them though.
Huh?
It's not meaningless to them.
No, it's not to them, but from a therapy point. Which treatment option is appropriate for clients experiencing it?
Oh, exposure. And that's when you.
Aversion is another name for it. It's used in treating fear more than the OCD part, is their anxiety. There's no such thing as response. Reaction therapy. Memory flooding is a technique used in treating post-traumatic stress, so that's why that one would be wrong. The following statement, true or false? The best way to help a client with OCD is to avoid talking about the excessive compulsive behavior. If the client feels ashamed of the behavior.
False. Don't get nothing done avoiding.
They may be ashamed and embarrassed, especially if their hands are raw from washing them so much, or somebody else put the clothes away and they went back and redid them, you know, and they get other people mad at them. It's important to offer encouragement, support, and compassion, to be clear that you believe they can change, and to develop and follow a written schedule with specified time and activities. To accomplish these tasks, you will need to talk with the client about the behaviors. So you give them other things to do so that they have to put other things in their schedule, so that they can't waste all their time doing their ritual. Okay, y'all okay with that one?
Mm-hmm.
Now remember we talked about in the DSM-5 that schizophrenia is under psychosis, and also your book is set up that way too. Schizophrenia is not the only psychosis, but it's the main one. It's the main one. And so, we'll talk about positive and negative symptoms of schizophrenia, and different theories and all of these things. Okay, so schizophrenia has distorted, bizarre thoughts, perceptions, emotions, movements, behavior, and categories are on here. Okay, so if you look, I might have something on the test about what's a positive or what's a negative. and it's not what you think. Positive is more like the hallucinations or the delusions are the main things. But those are the main things, the flight of ideas, the hallucinations, the delusions. And then the negatives are, more like the tendency to speak little or to convey little substance, feeling no joy, indifference, those kinds of things. Catatonic is where they, like are in a trance, motionless, or curled up in a fetal position. Flat affect, not able to concentrate. So the positive ones are the things that are bizarre. They're really bizarre stuff. The bizarre behavior, the, let's see which other one, but those are the main things, the delusions and hallucinations and the flight of ideas. And they'll just start talking to somebody you don't see, or they may tell you, we had one at Methodist North that told us about all her kids she had in Europe and all this bizarre stuff. I mean, she was the most psychotic one I'd ever seen, the stuff she told. And she'd turn around and just start talking to somebody. I mean, she was, and, she was worse than anybody I'd ever seen at Lakeside. I mean,
Where did you see her?
Methodist North.
North.
We went there when, during COVID, because Lakeside had so many COVID patients.
Mm.
It was right after COVID. We didn't go like in March and April, May. But we started back to class in July that year, so. Clinical. Isn't it funny how you base everything on COVID now?
Mhm.
Like what happened before and after COVID? So, and these are again the positive and negative. Examples of negative would be flat affect, lack of volition, inattention. They may have delusions of grandeur, whether they think they're God or that kind of thing, or the president, or so. And then these are some other positive and negative. Okay, so somebody who's schizophrenic, this is just a little thing, what's going on, just leave me alone, no, what was that sound, where am I, my own little world, I love you, I hate you, who am I, where am I, and it's usually diagnosed in late adolescence or early adulthood. The peak incidence is 15 to 25 years of age for men and 25 to 35 for women. And it's really only about 1% of the population, but still a lot of people. And then schizoaffective is they're severely ill, but they have a mixture of psychotic and bipolar mood. And you'll see that diagnosis a lot at Lakeside as schizoaffective. Anybody seen that that's been at Lakeside, schizoaffective?
Yeah, I had a schizoaffective patient.
So the clinical course, and that's why when you're at Lakeside, you can't like walk around giggling and talking to each other because they think they're talking about them.
Mm-hmm.
And that's why you can't have telephones out and all that stuff. So onset of broad or insidious, most with slow, gradual development. They've even had some that started out as ADHD and then went into full-blown schizophrenia. Maybe next month five. I mean, that's one of the things. And the diagnosis usually with more actively positive symptoms. That's where they start. When they start having hallucinations and delusions, that's when they realize something's wrong.
My patient from Saturday, she got ADHD, and now she has.
Yeah. It's like there's a real fine line. So.
And then this guy that I knew in the military, like, man, he was in the military, he was okay, and we was friends, and then all of a sudden he said that's his brain. So like, does it run in your family, or?
It is, there is a highly genetic component. So if somebody uses drugs and they haven't shown any signs, it can cause their brain chemicals to flip to it.
People with schizophrenia are supposed to.
Huh?
People with mental disorders don't. Drugs make it that worse. I mean.
Yeah, well, there's certain drugs that help
drugs
it.
make it
Yeah,
worse.
certain drugs help it. So, but if they try to self-treat, they'll probably on the wrong drugs. So cognitive processes, you look at their affect and their motivation, so you're gonna observe all that. And this is just a little mind map, the sensory impressions without external stimuli, and then illusions, they think somebody, like maybe you're carrying a pen like this, and somebody with schizophrenia that comes in to intake may think you're getting ready to stab them. So they're like, they may come out after you, because you're just holding your pen just as you're walking. I'm real bad about just holding my pen, like, from my years of being a nurse and supervisor, and somebody said, you gotta put that pen down. So I learned myself that I shouldn't do that. So delusions, they may think they're Cleopatra, or I had one that thought, oh God, but, affect. What a person feels is not in keeping with what one would normally expecting. This is one of the things you've been assessing if you've been in clinical, but you check to see if they have a blunt affect, or if it's kind of flat, inappropriate, or if they're over-responsive, or if it's kind of labile. And their motivation, whether they're ambivalent, they don't care one way or the other what happens to them. They may have all of a sudden curl up in a catatonic position, fetal position, and not move, and you think they're dead. I mean, they just like move, and then maybe hyper-excitement, and then impulsive behavior, where they just all of a sudden come at somebody. You may see them withdrawn and regression, acting like a child. And they are concrete thinkers, like, the concrete thinkers, if you say, we're gonna take you to the ER and they're gonna put a little dye in your vein. Well, my grandmother went to the ED and she died, so they think they're gonna die. That kind of thing. Or, it's raining cats and dogs. Oh, I don't see any, that kind of thing. And then they're, disorganized behavior, thinking, paranoid, that kind of thing. So the clinical course, 2 patterns. Ongoing psychosis, they never really fully recover. And these are the ones that used to be in the, institutionalized before they had meds for it. And then some of them they put on the street, and so they're homeless because they don't take their meds. And they don't really want to have a home, because that's what they do. And then episodes of psychotic symptoms alternating with episodes of relatively complete recovery. So people can have schizophrenia and function as a normal person if they are on their meds and they have their therapy. So long-term course intensity of psychosis diminishes with age, disease becomes less disruptive, clients may live independently later in life, and many have difficulty functioning in the community. So, I know you've seen, shows where, like, somebody with their family member had schizophrenia, and then they quit taking their meds, and now they're out on the street somewhere and they're looking for them, that kind of thing. So, and these are just some of the,
What is the intensity of psychosis diminish with the age?
It can't, well, part of it maybe they've been taking medications, and it probably has to do with chemical imbalance. It doesn't always. So, it just, I guess it's just, maybe they just get used to functioning in their little world, and it's not so obvious. But, here's the biological theories. Genetic risk, neuroanatomic and neurochemical factors, less brain tissue and cerebral spinal fluid, dopamine excess and serotonin modulation of dopamine. So that's a major chemical imbalance. And then there can also be, they think, an immune response to certain viruses, and researchers focusing on infections in pregnant women, possible origin. That's just a study, respiratory ailment. So there's a lot they don't know. Still after all these years of dealing with it. And this is just a little thing about the client, their affect and their thought, their perceptions, illusions, depersonalization, and and then their thought processes, they're more like autism, concrete, magical things, or things they can cause something to happen, automatic, knowing, Colio, where they can like watch something on, memorize an ad, echolalia, and, like on TV, and then you'll hear them like quote you ask them a question and they tell you they quote the whole ad to you, the commercial, and it's like, what? And then, yeah, and autistic kids do that too. And then, withdrawal, ambivalence, all of these are just the blunt, flattened, inappropriate, all those. Okay, cultural considerations. Ideas considered delusional in one culture, possibly commonly accepted by other cultures. Auditory or visual hallucinations is a normal part of certain religious experiences in some cultures. Cultural concepts, and so how people experience and communicate distress is, some people might not recognize it as schizophrenia. And then ethnic differences in response to psychotropic meds. People's chemical imbalance causes them to sometimes react differently. So conventional, I've given you the handout on antipsychotics, so that's the main one y'all will go by. But atypical antipsychotics, they sometimes use those for diminishing the positive symptoms and lessening the negative ones. And let's see, there's some that they can give by injection, and if you're on the street, it can take be longer lasting. It says may take several weeks of oral therapy to reach stable dosing level before transition to those injections. And I know during COVID there would be nurses going out on the street finding some of the homeless people and making sure they had their meds and all and the TB tests and all that. So EPS we've already talked about that you can see as side effects, and the tardive dyskinesia we've talked about. They can have seizures, and we've already talked about neuroleptic malignant syndrome. And again, these are signs of it. I might have something on the test, and you tell me which syndrome it is. This is the one where they have the fever. Okay, non-neurological side effects. Those are also in your book, but these are some of them. Weight gain, sedation, photosensitivity, these are all ones that are on your handout that we've talked about. And then psychosocial treatment, again, some of the same things, individual group therapy, and of course they really have to make sure they're taking their medicine. That usually they need somebody in their family that's a schizophrenia patient that makes sure they're taking their meds, because they might just have a moment of grandeur and think that they don't need them anymore, and that's when they get worse. And so so they do need somebody sort of guardianship, even though they may be able to function and have a job, but they still need somebody because their tendency is going to be to quit taking them when they feel better.
That's when they need the shots.
Mm-hmm. And then cognitive enhancement, and then family education. So assessment, of course, you're gonna, do the mental health assessment, how they look, their speech, and all of those. And then mood and affect are flat and blunted. Thought process, you can see a lot of times withdrawn with delusion, and all the things we just talked about, the different kinds. They can have all kinds of hallucinations: auditory, visual, olfactory, tactile, all of these. And their judgment and insight is usually going to be impaired. So, and they have a loss of ego boundaries. They, back to Freud, the ego, the superego, all that. They don't have any boundaries. Roles and relationships. They may have social isolation because people think they're weird. Frustration if they are in a family able to do what they need to do. And then physiological and self-care considerations, where you'll see them when they're doing well, they may be well groomed, but when they quit taking their meds and they're not doing well, they may do, poorly. So, there's gonna be a risk for violence, a risk for suicide, delusional thinking, hallucinations, personal identity disturbances, and impaired verbal communication because of the concrete thinking. And so, usually there's acute psychosis, you're gonna focus on keeping them safe and other people around them safe, and help them with contact with reality. Well, I understand that you're hearing those voices. Tell me if what those voices are telling. Are they telling you to do anything? And you don't ask them a lot of questions, but you wanna make sure that they're not being told to kill you or somebody else. And then, but then you say, I understand those voices are real to you, but I do not hear them. And, you interact with, you know, in the milieu, you'll have to interact with others, express thoughts and feelings in a safe, sociable, acceptable manner, and adhere to intervention. So, also, the therapeutic communication, the therapeutic relationship, and you have to plan what to do if they're having delusional thoughts. Usually the treatment team decides how to handle it. It may be medications, actions for hallucinations, what you'll do if they're hallucinating, they're acting out, and then coping with socially inappropriate behaviors. So, in your book, it talks about some of the, on table 65, signs of relapse, and, do y'all have your books? Or you can just pull up your e-book. 16.5. 16.5. Because it's under schizophrenia.
What page?
Okay, I'll tell you.
375.
Yeah. And look over, it tells you what to
Yeah.
do if a patient has delusions, if, and, 16.5. So signs of relapse are gonna be impaired cause and effect reasoning, impaired processing. All of a sudden, they're not eating, they're not sleeping, they're not exercising, they're tired, they're lonely, they have mood swings, they may not be taking their meds, they feeling bad about themselves. You just know something's wrong. Hopelessness, loss of motivation, anxiety, worry, and all of those, and they forget. So those are the ones that the family may actually have to bring in and, you know, have them committed, because they have to go to court and prove it within about 72 hours, you know, if it's the weekend, that kind of thing. So, but the family does need to know, what to look for, because if they start to have problems, they're probably not taking their medication. And then age-related, rare in children, never diagnosed before age of 5. Typical onset is teens, especially in males. Especially if there's a family history of it, it might start to manifest. Might initially start to manifest as depression, that type of thing, and then, if they start to have, delusions or hallucinations, then there's some concern. Onset of symptoms, 20s for females. I know one that we took care of on behavioral health at LeBonner, she was a St. Jude patient with HIV, and she was pregnant.
Wow.
They put her on our unit. Of course, we had, you know, kids from 5 on up there, and she was 17, I think.
Mm.
And, I hadn't worked OB in years, and I had to listen to fetal heart tones, but the good thing about it is if we couldn't hear anything, we could send them over to the med and an ambulance and check her. But But I just remember one of our infectious control doctors said, we are never putting a high-risk pregnancy on this unit again. I just remember him saying, and I thought, fine with me, you know. So I think her water broke or something, I mean, it was, and she had HIV, and we didn't know that much about HIV like we do now, you know, and so, but anyway, that was my experience with us as females, and that was younger. So, variety of long-term outcomes, about 1/4 also have dementia, and, they start to decline in their health. And then some of them, the positive symptoms go away, but then the other does not. So community-based care, they may need housing, like group home housing, or they may be able to live independently. And they have, you know, hopefully they're in a city where they've got good community treatment programs, good behavioral home health care, where somebody comes in and checks on them, or if they're on the street, that there's a nurse that goes out and checks on them, community support programs, and then case management services where somebody's following them. So, so you wanna help them manage their own life, make effective treatment decisions, and just improve the quality of life to the point it can be. So a lot of times they can live alone, but they may be, you know, they can have a job, like the men sometimes are like janitors and that type of thing, and they can function in society, especially if they're on their meds. But they still may be, if they go to a family outing or something, like a holiday thing, they may misinterpret things because they're concrete thinkers. If somebody says something or tells a joke, they may not get it. And then, accurate identification of those at risk, and then recognize any of the signs. So self-awareness issues, again, these are ones that are similar to what was in your book. Recognize their behavior, that they're suspicious or paranoid, and remember not to giggle and laugh in the milieu because they think you're talking about them. And the nurse might be frightened, but especially a new nurse in psych, but so they just have to acknowledge those feelings and take safety measures. I make sure y'all are safe. I have to make sure that everybody's out where I can see them, and I walk them up, you know, to make sure everybody's always safe. Plus, we have techs in the milieu, and I can tell you the one where the safe room is, where we don't go, in pediatric part, the bridges part, adolescents. They have these huge guys over there that are sitting outside the doors that they're on, you know, one-on-one. Some of my students were afraid to go in there, and I said, no, it's okay, you come on in, I want you to see the safe room. And there was a big guy sitting there watching somebody on the other side, and one time we went in there, there was somebody in the safe room, so we just kinda, you know, went on, and when he came out, he was turning and looking, and you knew he was oppositional defiant just by that attitude he had. And I just told the students to step back and look the other way, you know. So you don't take their success or failure personally. It's not your fault. You do the best you can, and then focus on the amount of time the client's out of the hospital, because that's good. You know, if it's not the revolving door. If they're out for a year, that's great. So visualize, you know, as they get better. So, is the following statement true or false? Positive symptoms of schizophrenia include a flat affect and social withdrawal.
False.
They're negative symptoms. So y'all do need to know negative and positive symptoms. Which item is a neurological side effect of antipsychotic therapy?
Granulocytus.
No,
Tardive dyskinesia.
And that's the
Non-neurologic side
That's
effects.
the tongue roll,
That's
and then the
EPS.
lip smoke, and the lip smacking and the tongue roll.
Yeah.
And they can, yeah. Okay, is the following statement true or false? A nurse should confront the client's delusions.
True.
False.
just stop saying that, you know.
This is cute.
So, okay, we gotta look at the book, see what I respond.
Well, yeah, your response would be, I understand that those are real to you, just like you do with,
But I don't see anything.
well, but this one would be what they're thinking, but that is not what I believe, you know. Like if they think they're God, you know.
Now, they just-
Yeah. That's a delusion, or they think they're the president of the United States, or the king of Sheba.
Okay, like, I'm the president of the United States, so will you say the president of the United States is such and such, such and such? I don't think you're the president of the United States.
You just say, you just don't buy into it, you don't have them keep telling you about it. You just, I had, when I was in nursing school, my clinical was at the VA hospital, and I had, somebody who thought, a guy who thought he had a baby in his stomach, and while I'm talking to him, he's seeing pink demons and all that stuff. When I was in nursing school, we had to actually do a skit and video ourselves with one of our patients. So I guess we did it with another student, I can't remember. And I remember that's the one I picked. I still remember that one. It was so bizarre. Okay, y'all okay? Y'all need to stand up? Y'all doing good?
Oh, so far so good.
Okay.
Yeah.
We're getting there. So mood disorders. These are your, learning objectives for it. And, so your mood and affective disorders have a whole chapter by themselves. And, these are ones that, long-term sadness, agitation, or elation. And, until the mid-1950s, there wasn't any treatment available for serious depression or mania. And this is just, shows bipolar type, and bipolar 2. So you've got your mania and your depression. Some people are more manic, and some are more depressive, and some are, well, sometimes normal. And then your hypomania are people that they're not really manic as far as they're gonna like come out and like looking like, I remember the first one I saw when we went a tour at the regional one was, they used to have a psych unit over there. I don't think they do anymore. They don't. But they did then, and she was like she was a princess or something, and you know, red dress and dancing everywhere, and she would be really manic. She was in a manic stage, and then so some people are more here, some people are more here, but hypomania, they may just be a person who functions, who has to take meds, and then they're fine. So you can have your bipolar mix, where you have, sometimes they're manic, sometimes they're depressive. You have the bipolar type 1, they're manic at least one depressive episode, and bipolar 2, recurrent depressive episode, with at least one hypomanic episode. So, most common psychiatric diagnosis associated with suicide. Depression is one of the main problems. So major depressive disorder, episodes last about 2 weeks, over 2 weeks. So, related disorders, they may have persistent depression, disruptive mood dysregulation, cyclothymic disorder, substance abuse induced depressive or bipolar disorder, like if they're taking, some people taking drugs, they really probably, this would have never come out if they hadn't been taking drugs, and then this comes out as bipolar. So then those patients you call dual diagnosis. You'll see some of those at Lakeside, and there's a unit they tend to put the dual diagnosis if, I guess if they're more into the, like if they're addicted to drugs, they may put them on another unit first to get them kind of stabilized, and then move them to the addiction unit. Postpartum blues, depression, or psychosis. When I was director of pediatrics in St. Joseph, Missouri, that's how, you know, Kansas City, that's why I told everybody I was for the red team, because we lived up there. I didn't really care, but anyway, I was, had a mother that came over there and said that she was still on the OB unit and the baby was on our unit, I guess there must have been an infection or something, I don't know what was wrong with her. The baby was on our unit, the baby had an infection. She said that my nurses were poisoning the breast milk that she had in the refrigerator. My nurses were poisoning the breast milk. So, I called the OB person over and she goes, let's call somebody. And we got decided, we decided, and she ended up on the psych unit, that mother did. And she was probably schizophrenic, you know. So that's what I'm telling you, it doesn't matter where you work, you're gonna encounter people that you're gonna have to assess and maybe call somebody else for help. But she ended up, we had a psych unit and it was we were 30 miles out of Kansas City, so we had a psych unit in our hospital. But, anyway, the seasonal affective disorder, some people it's more seasonal, and then, premenstrual, some people have problems with it, and then non-suicidal self-injury, where they cut themselves and that kind of thing. Are you leaving? You have to go to work?
Oh,
Yes, ma'am.
Major depression, feeling of sadness, despair, or discouragement. Overt manifestations can be culturally specific, and then occurs in all ages. So the affect is gonna be sad, dejected, hopeless, angry, grooming, that kind of thing. So you may see them just not eating, not sleeping, muscle tone, real flabby, no energy. They may be constipated because they're not eating or drinking, right? That makes them constipated. And for women, it may be menstrual problems. And then they dwell over everything bad that's happened to them. It goes over and over in their mind. That's all they can think about. Decreased awareness with delusions and suicidal ideation. Their delusions are more like, I'm not worth anything, I'm a failure, that kind of delusion. If they're in the depressive stage. And then, they may have poor judgment, indecision, impaired reality testing, they may have some hallucinations. That's when the bipolar switches over to psychotic. You can have a psychotic episode, but you're not always psychotic. And then impaired social functioning, impaired occupation, problems at work, withdrawal from family, not going to work. Yeah, I had a student nurse one time that just quit coming to school and clinical, and she was severely depressed. I remember she had poor judgment too, because she walked in a room that, when she was in clinical, that somebody in that, the mother had lit candles all around the kid, and she didn't actually realize that was a problem. That the mother had lit candles all across the room, you know. So, judgment, that would be, depression, these are some of the nursing diagnoses you'll see. These are ones that when you're at Lakeside you can use, and the little handbook, and hopefully everybody got their handbooks turned in that finished on Sunday, and then I'll be able to, the next instructor will be able to give those to the next group. So self-esteem, sorry this was kind of small, but it's in your book. They have trouble with acceptance, cast doubt on their worthlessness. You don't want to just you just want to accept them as they are. You don't try to cheer them up. You help them reevaluate their strength. We do competitive games sometimes at Lakeside, but sometimes they don't want to do it. You don't make them do it. They may need, in the main depressive state, may need help with ADLs. You want to seek the client out, use silence, maybe they'll start to talk, look at their nonverbals. If they're in a good mood, then you're a little bit more upbeat. Help them discuss their thoughts, eliminate the word like, and don't overwhelm them. The client will initiate interaction, would be an outcome, sit through a one-to-one interaction. And then coping ineffective, something you could do is help them express their feelings, like anger, so you would say the client will express feelings, demonstrate more adaptive ways of coping. And so, to make them measurable and clinical, I have you go, the client will express 2 feelings, and stay away of coping during my 9 hours. Just so it's a SMART goal, it's measurable and time limited. So hopelessness, you want to acknowledge their feelings, reframe, establish attainable goal, provide hope, and allow to reminisce. And you can say the client will say 2 things, that would be long-term, this one would be, but a short-term goal would be they will say, 1 feeling of hope today, within this shift. Activity levels, they really may not have any energy, so you have to encourage activities and help them develop a schedule, and, they don't have to like it, but they still need to do it, that kind of thing. And then nutrition and elimination, of course, they need high fiber foods if they're not drinking, a lot of fluids, they need water, they need, make sure that they're eating and drinking. Sometimes they just don't, when they're depressed, they don't eat because they're depressed. Self-care deficit, so 1-to-1, accept dependency, show respect. You want the client will increase participation in self-care, especially if they come in the first day and they're really, excuse me, lose my voice. They're really not well kept, and they're getting better when they start to get up and take a shower on their own, that kind of thing. Safety, there's always that threat of suicide and, self-harm in some way. So, they'll make a short-term verbal or written contract. So if somebody comes to you, this happened to me when I was a manager in the, I think it was urgent care in Lavonner. One of my nursing assistants told me that she was thinking about killing herself. So I called the psychologist on campus, and she helped me write out, an agreement where she said that she will seek out somebody and that she wouldn't do it. So they let me go ahead and send her out, and then she was gonna get therapy. And, but I didn't know, that was the first time I had to do, it was before I'd ever worked behavioral health. I had to write the no harm plan, and she told me what to write, and I typed it up and had her sign it, and then she didn't kill herself. She went out and to get some help, but.
Oh, good.
So I'm telling you, it doesn't matter what you're doing, you're gonna, deal with it. So, most often diagnosed in adulthood, but sometimes they identify it in childhood, and of course, everything's affected, their affect, their behavior, their thoughts. So when they're manic, they're just everywhere, they're euphoric, hyperactive, they're intrusive, they're they're disrupting the whole milieu usually. And, of course, they may become exhausted, and, they may not take time to eat or drink. They don't have any insight, they have flight of ideas, they're delusional, they're, think they're wonderful, they're the best one there, they're hallucinating. And then, let's see, those are just the levels we mentioned. So the manic diagnosis, these are some of the things you would go through for your multi. So physical needs, again, the nutrition and protecting them. Social interactions, people that they are dating somebody with bipolar, they may have limit setting, they may be very distractible. You have to convey acceptance and give clear directions. Client will interact appropriately with others and does not intrude. They may be the one that just talks all the time and interrupts people and that kind of thing. Risk for violence, they can become violent. And thoughts, perceptions, delusions, flight of ideas, they'll complete tasks. coping ineffective, you want them to make sure that they realize there's consequences of their behavior. And then lithium is the magic stabilizing drug, and we already talked about the toxic levels, right?
Mm-hmm.
And we know that sometimes the toxic level is real close to the therapeutic level, so there's a real fine line between that. And then one of the things you'll see are the tremors of the hand, and one of the polyuria, the thirsty, nauseated. And so these again are on your handout also about lithium and side effects. Again, we think there's a genetic component, and there's, chemical imbalance, and could be sometimes a hormonal imbalance also. And, we know that heredity is a big factor in it. We know that serotonin and norepinephrine are the two major, mood disorder chemicals, and then we also know acetylcholine and dopamine are also related. And I gave you the handout, the chart last week in your PowerPoint that talks about which ones are affected. Let's see. I know y'all are getting a little bit tired. What time is it? I'll make sure we get through all this till it's 12. So I wanna make sure we have time to go over the test. The Hamilton rating scale again is one of the things where we're looking at their mood and their tendency for suicide, all those. And then somatic complaints, some cultures, manifesting cultures that avoid verbalizing emotions. So they may, if somebody has a stomach ache or something, that may be what they are seeing rather than the actual depression. So we know if they don't treat depression, it can last weeks, months, years. With medicine, they can clear up quickly. A lot of times it will reoccur, and some people with severe depression do have psychotic features like we talked about. And then I've given you the meds on those handouts. The other thing they use sometimes is ECT. They still do that. I showed you in your book last week where ECT was. At Lakeside, they do it on Fridays, and when they do it, they, sedate them, and then they shock them, and their heart actually stops for a minute, and it takes away part of their memory. And then psychotherapy is another one that we use a lot, and then, there's some other ones they use, like the vagal nerve stimulation and some deep brain stimulation. Again, your assessment is so important. There's rating scales that they can use to, box 17.1. And then, of course, you gotta keep them safe. Suicide precautions, they may not be allowed pencils or anything sharp. Therapeutic relationship and communication, and then the same as others teaching. The bipolar, is considered extreme mood swings with mania and depression. And let's see, this one, you got the handout on the meds. And they may also do psychotherapy, but not during the manic stages. It doesn't work because they can't concentrate. They're just too manic during that stage. So this is what we keep talking about, 17.1, and these are some of the side effects, and most of these are also on your handouts. These are just the ones that were in your book. So assessment, again, these are very similar to the others. Let me see if there's anything different. Okay, the depression common among older adults and markedly increased during medical illness. Psychotic features more frequent than in younger people. so, part of it, they become tolerant to their medication, and that's where you're gonna see the ECT use done. And then community-based, very similar to the others, if they need intensive outpatient, they give it to them. And, you know, we need more efforts to prevent and early detection, especially for adolescents. And that's where the school, I think they're trying to put more, people with psychiatric training out in the schools. Memphis has not been one of the best cities to have a therapist in every school, and so they're working on all that. And then, with school kids, you'll see, sometimes that the parents have alcohol or mental illness issues. There may be a history of fighting for the child, and, they may have access to weapons in the home. All those are very, great concerns. And, I know one kid said the other day when he was listening what was going on, he said, yeah, I got in a fight and hit my teacher, but my mom came up there and beat her up. I went to juvie and she's been in jail a lot of times.
50 times.
You know, and
Both of them, yeah.
yeah, I mean, and this is a little bitty kid, I mean, you know. The self-awareness issues, you know, you wanna help them understand their own feelings, and then, when exhaustion is, we told you was possible when they get so manic, they don't eat, they just run around, and then help them to journal and talk with colleagues. So is the following statement true or false? Depression is one of the most important risk factors for suicide.
True.
True.
Is the following true or false? Clients with depression often exhibit anhedonia. Nothing gives them any pleasure. Which medication would be most appropriate for the treatment of mania? Okay, let's see, we're on to the last chapter. Eating disorders. What do y'all know about eating disorders? Did y'all talk about eating disorders in PE? Y'all didn't do anorexia?
Mm-hmm.
So, eating disorders, y'all know anorexia nervosa, and then bulimia. The anorexia nervosa, let's see if you could have that chart. The one that we see the most is they just eat hardly anything. And, then the bulimia, they eat everything and they, vomit. And they may be binge eaters, not eating, they may eat mud, and, but the biological factors, they do think there's a genetic component, in disruptions in the hypothalamus, neurochemical issues. Sometimes it'll be athletes that they start out trying to lose a lot of weight so that, you know, they can be active. And then it becomes, because of the tendency, they become anorexic. One of the main things you have to remember is you don't tell them they look good if they're losing weight, because if they're 80 pounds and you say, oh, you look good today, they think, oh, good, I'll lose 5 more pounds. And when you weigh them, you don't ever want to look them and have them look at the scale. You want to have them backwards from the scale so they can't see how much they weigh. And you have to make sure they'll put stuff in their nightgown pockets or whatever. They're trying to weigh more. And sometimes you'll see them like jumping rope or doing continuous activity because they don't want to gain any weight. They want to keep losing. And then people with bulimia, they will eat everything in the refrigerator and then they'll make themselves vomit. And this is somebody with anorexia. They're really super skinny. They do tend to run in families. You see a lot of females with the anorexia nervosa. It's really hard to treat. We had a psychologist that was able to treat it, but I think she's retired now at Lavonner. but a lot of times they would send them to a different state. If there were some that were just gonna die, they just couldn't, no matter what, they were just determined to die. And that's a picture of somebody, and like I said, they think now that there may be a hypothalamus involvement with it, and then of course increased levels of serotonin, and low levels as well as low platelet levels of monoamine oxidase have also been found in clients with bulimia in the binge and purge subtype of anorexia nervosa. So part of it is they will like cook for everybody in their family, and then they won't eat it. It's like sometimes they're in a very controlling family that's very overprotective, and the only thing they have any control over is food. So that's where it gets manifested. And that's the thing with autonomy, exerting control, and so that's the ones you see the most are young teens that are I take care of gobs of them because LeBonner used to get all of them, and then we would have to send them out of state usually if they weren't able to treat them. And cultural considerations, in the United States, they've always, everybody's gotta look like the Barbie doll and skinny, and so now you'll see people at, clothing ads now have bigger people in them. It's not always the skinniest ones. And like I said, 14 is usually when you see it, sometimes a little bit younger. And in the early stages, they have a negative body image related to their appearance, and then they think they can control it by not eating. And then as it gets worse, they become more depressed, and they isolate themselves and that type of thing. And then physical problems, a lot of times they don't have periods, they're constipated because they don't have any fluids, and all of these that are listed here. You'll see dental caries, you'll see bradycardia. I mean, they're gonna end up dying if they don't, some of these guys. Sometimes what they'll do is initially they will put them in the hospital and give them an NG tube just to get something down them until they can get them the counseling they need. Because they're gonna have hyponatremia, hypokalemia, all those things. And sometimes you'll see adults with it. There was a nurse that worked in our unit that she would never eat with anybody, and later on we found out that she was anorexic. She would always go somewhere for lunch and make calls, and we never saw her eat, so we didn't think too much about it until we found out. She was like PRN or something. So onset usually between ages of 14 and 18. Okay. Let's see what else I need to tell you. Some of the treatment. And bulimia, like I said, is the binge eating. And sometimes people that go into mental health actually are in there to work out their own problems. I remember our night nurse on our behavioral health unit came over from MMH&I, and we only had one nurse a shift, so we didn't have that many patients, and we noticed that everything would be gone in the refrigerator. And then I go in and I say, this room smells like somebody vomited in here, and I never put it together until a little bit later. And she had bulimia, and she had really horrible teeth and everything, so she was older, so long gray hair, she had been doing this for a long time and was still alive. I guess she ate enough but I don't know whether I never knew whether they counseled her or what, but I know she left, so I don't know what happened. But anyway, bulimia can go on into adulthood, the binging and purging, and they start to realize they have a problem. So they may store food in their cars, their desks, everywhere, so that people don't see them eat. You may only see them eat a salad or something, but then they're eating somewhere. And isn't that gross to eat in the bathroom? But she's hiding. And so they have a lot of guilt and shame and disgust about their behaviors, and they're embarrassed for anybody to know. And you do see more guys with bulimia than you do with anorexia. And more than any other eating disorder. And they're more likely to be overweight as children, and then teach about their weight, and then they start to not let people know they're eating. These are some of the complications. Trying to get to our case studies, what time it is. There's somebody with anorexia. And again, family counseling is real important, especially if they're teens and they're still at home. And eventually, if they don't get better, they're just like, looks like this. And, so, there's screening, nursing interventions I've got listed, but the main things are you don't ever say they look good and you don't let them see their weight. And then you, have to have a sitter with them if they're like binging and purging and you're on a regular hospital floor, you're gonna have to put a sitter one-on-one because they'll sneak in the bathroom and vomit, or, they will sneak in and like jump rope or something, they'll do something to keep losing, or they'll exercise constantly, they'll do things, so, that's the main thing, the self-monitoring is a good thing. We had one anorexic that her food would get to a certain point, like here, and then she'd feel like she had to vomit. So we did this psychological thing for the psychologist, and we would walk her through it. We'd say, okay, swallow your food, okay, close the gate, and then there's another gate, open and close it. So we actually did a thing where we, kind of talked her through it. I don't know long-term how she did, but. And then they have the cognitive behavioral therapy, where they have a thought, they try to block it and, change their behavior. And so with this one, it helps them identify their emotions and develop coping strategies. So, a lot of times they're not aware of their own feelings, and, they may express it in terms of somatic illness, and the nurse can help the client to, help recognize their emotions. And you can say, are you sad, happy, anxious today? And, help them be aware of how they're feeling. And this is just more detail on the cognitive behavioral theory. So what it does and how it helps. And ultimately, you're helping them manage their emotions using relaxation techniques or distraction with music or another activity. Of course, they're writing everything down, all that. Of course, the nurse has to be aware. Nurses can get really frustrated with these patients because, they're sneaking food, or they're sneaking, not eating it and throwing it away, and so the nurse has to be really careful to accept them and not to get frustrated with them. I mean, I had one time in the behavioral health unit that they were putting an NG down her, and she was so oppositional defiant. She goes, after I put it in, she goes, throws it on the floor, so she was very defiant. So, but, so it is easy. Well, for a nurse who does long-term care with these patients, it can be frustrating. Is the following statement true or false? One current biological theory about eating disorders that involves a disruption in the cerebellum portion of the brain. It's more the hypothalamus. What's the typical age range?
B.
14, remember, it starts at 14. It's true or false?
Like, you saying they monitor themselves?
That they what?
You saying like they will monitor themselves? Self-monitoring, like they monitor themselves?
It's the same, yeah, self-monitoring is an effective, so it's drastic.
Pause.
Do you want me to go back to that one?
Yeah.
Okay. Is that effective for them to monitor themselves? But somebody with bulimia, they can use it with that because, they're more likely to keep up with what they're eating, but it takes a lot of counseling for that. Okay, we're gonna stop there, but let me show you, I've got a bunch of case studies for y'all, but let me see something. Y'all need a break and then come back and do some case studies. Okay, let's take a 10-minute break and then we'll stop the case study, it's time to go over that test, okay? And then the case studies. You leaving?
I just want to pop out and show you.
How do you say the name? Renaya, right? I was calling it Brainy. Okay, so I will get back with you today on that orientation.
Okay.
And then the prep you, I need to reopen. Which one?
The one
The first one?
Thank you.
Professor, you said all we're doing is going over the test when we come back?
No, we're gonna go over the case studies. I've got case studies. Sorry, y'all, there's a lot of content on this test,
Mhm.
yeah.
Those the case studies from the book, the electronic book.
I don't think they're the same one. Are they the same one? Have you looked at
That's
them?
what I'm asking. I saw the ones on in the book. I was just
I don't
curious.
know if y'all have these or not in your, these, I don't think they're the same ones. We'll go over a few of them.
Okay.
I don't know which ones you have in your book. I don't think they're the same ones. But they might be.